Hello, good morning everyone. We are the Group 1 and the first presenter, and today we will be discussing about responses to altered ventilatory function using the 5 phases of the nursing process, namely the assessment phase, nursing diagnosis phase, planning phase, implementing phase, and the evaluating phase. In this way, we will be able to integrate the nursing process in the care of the client with altered ventilatory function in the critical care settings. First, let's discuss the assessment of the ventilatory function. Correct diagnosis depends on an accurate health history and a thorough physical examination. A respiratory assessment can be done as part of a comprehensive physical examination or an examination in itself. Use judgment in determining whether and parts of the history and physical examination will be completed based on the problems presented by the patients and the degrees of respiratory distress. If respiratory distress is severely, only obtain pertinent information and therefore a thoroughly assessment until the patient condition is stabilized. In assessment phase, we have subjective data that includes the important health information of your patient as well as the functional health patterns.
We also have the objective data that includes physical examination and diagnostic studies.
Now, let's proceed to the important health information under your subjective data. This includes the past health history. It is important to determine the frequency of upper respiratory problems such as colds, sore throats, sinus problems, and allergies, and if seasonal changes have an effect on these problems. Next is medications. Take a thorough medical history. Assess and document both prescription and over-the-counter medication. Obtain information about the reasons for taking the medication, its name, the dose, and frequency, length of time taken, its effect, and any side effect. Next, we have the surgery or other treatment. Determine if the patient has been hospitalized by the respiratory problems. Note the doses, therapy, including surgeries, and current status of the problems.
Next, let's proceed to functional health patterns. Firstly, we have health perception, health management pattern. Ask the patient if there has been a perceived change in health status within the last several days, months, or years. Next, nutritional metabolic pattern. Weight loss is a symptom of many respiratory diseases. Determine if the weight loss was intentional, and if not, if food intake is altered by anorexia for medications, fatigue from hypoxemia or increased work or breathing, feeling full quickly from lung hyperinflation or social isolation. Next is elimination pattern. Healthy elimination habits depend on the ability to reach a toilet when necessary. Activity intolerance, secondary to dyspnea, could result in incontinence. Activity exercise pattern. Determine if the patient's activity is limited by dyspnea at rest or during exercise. We have sleep-rest pattern. Determine if the patient wakes up because pulmonary problems. Also, we have cognitive perceptual pattern because hypoxia can cause neurologic symptoms. So ask the patient about apprehension, restlessness, irritability, and memory changes, which can indicate inadequate cerebral oxygenation.
Also, we have self-perception, self-concept pattern. Dyspnea limits activity impairs ability to fulfill normal developmental role functions, and often alter self-esteem. Also, we have role relationship pattern. Acute or chronic respiratory problems can seriously affect performance in work or other activities. Next is sexuality reproductive pattern. Most patients can continue to have satisfactory sexual relationship despite marked physical limitations. Also, we have your coping stress tolerance pattern. Dyspnea causes anxiety and anxiety exacerbates dyspnea. The result is vicious cycle. The patient avoids activities that causes dyspnea, becoming more deconditioned and more dyspneic. And lastly, we have value belief pattern. Determine the patient's adherence to the management regimen.
Now, we've done with functional health pattern. Next, we'll proceed with the physical examination. Vital signs including temperature, pulse, respirations, blood pressure, and oxygen saturation obtained by pulse oximetry are important data to collect before examination of the respiratory system.
Physical examination has 4 techniques. We have inspection, palpation, percussion, and auscultation. Now, let's proceed with the diagnostic studies. First, we have your blood studies. Under your blood studies, we have your hemoglobin. This is the test that reflects amount of hemoglobin available for combination. We use the venous blood. So, for male patient, the normal range of your hemoglobin should be 13.2 to 17.3 grams per deciliter. For females, however, we have 11.7 to 16 grams per deciliter.
Next, we have hematocrit. This is the test that reflects ratio of RB cystoplasma that increase hematocrit, which we call polycythemia, found in chronic hypoxemia. Venous blood is also used in this diagnostic or laboratory test. For the normal range for males, we have 39% to 50%. For females, we have 35% to 47%.
Also, under your blood studies, we have your arterial blood gases or your ABGs. Arterial blood is obtained through puncture or of radial or femoral artery or through arterial catheter. It is performed to assess acid-base balance, ventilation status, need for oxygen therapy, and change in oxygen therapy or change in ventilator settings.
We have oximetry. This is the test to monitor arterial or venous oxygen saturation. Probe attaches to finger's toe, earlobe bridge of the nose for spot 2 monitoring, or is contained in pulmonary artery catheter for SVO2 monitoring. It is used for intermittent or continuous monitoring and exercise.
Next, we have your radiology. First, ventilation perfusion or your VQ. It is used to assess ventilation and perfusion of lungs, intravenous radioisotope given to assess perfusion. For the ventilation portion, the patient inhales a radioactive gas, usually xenon or krypton, which outline the alveoli. So, for the result, normal scan shows homogeneous radioactivity. Diminished or absent radioactivity suggests lack of perfusion or airflow, and ventilation without perfusion suggests pulmonary embolism or ambulance.
Another one is pulmonary angiogram. It is used to visualize pulmonary vasculature and locate obstruction or pathologic conditions. Example, your pulmonary embolus. Contrast medium is injected through a catheter threaded into pulmonary artery or right side of the heart. Series of X-rays are taken after a contrast medium is injected into pulmonary RRD. Chest CT scan is replacing angiography as it is less invasive.